Well, thank you so much for inviting me. I spent much of my career in county land. I just want to thank you for your service. It has been a really challenging last 3 years. I speak from that personally in this role, and also with working with all of you. It can be overwhelming. And to be honest with you, this slide deck is a little overwhelming with the amount of content that's in it. So for this audience, I don't really have to go into any background. You know what our circumstances are. We are in the midst of a behavioral health crisis. We are in the midst of a homelessness crisis. We have significant infrastructure capacity challenges. We have some of our criminal justice partners here. We've got a number of people with serious behavioral health conditions who are entwined in the criminal justice system. And we have significant ethnic and racial disparities in access to care. So these are our enormous challenges that we're tackling. So what are our strategies? So at Health and Human Services, many of you I also saw are in a similar situation as me, housed at a Health and Human Services. For those of you who aren't aware, we have 12 departments, everything from the Department of State Hospitals to the Department of Healthcare Services to the Department of Social Services. We also have 5 offices, anything from the Office of the Surgeon General to our Office of Youth and Community Restoration. So really a lot of scope here in Health and Human Services. And when we, about a year after or a year into the pandemic, we really focused on some core priorities. And no surprise, because you guys have been on the receiving end of much of this, that one of the top priorities for this administration is to advance the behavioral health system. And that's not just the behavioral health system for many of the people that you serve in the public sector and people who have more serious mental health conditions, but for all Californians across the entire lifespan. So that's our responsibilities through overseeing our commercial plans, as well as our Medi-Cal managed care plans, as well as our specialty plans that are managed by our counties. So our top priorities in behavioral health are to reduce stigma, misinformation, and discrimination. We want to reduce the delay in access to treatment. We want to reduce disparities and advance equity, particularly around BIPOC and LGBTQ+ communities, and to increase access to culturally responsive care and culturally defined programs. We want to reduce the number of individuals in prisons and jails who have mental health and substance use disorders. Over the last decade plus, the concentration, I don't have to tell you, of this population in our prisons and jails is multiplying. We want to increase the high quality of community care placements. You guys deal with these challenges every day. You just simply don't have options to provide people residential treatment. We want to, of course, reduce homelessness and also really housing insecurity for our populations that we serve who are living in poverty. And also to just increase the satisfaction and trust that people are receiving high quality services. We really tried to put out something that was appropriate for like the public and a lay person that would really describe some of our major initiatives in kind of simpler terms, and how we are making investments across even this particular representation of the behavioral health continuum, which is also kind of oversimplified, to be honest. But what we're going to go through today is really talk about how during the time in this administration, these are areas where we feel we need to make investments for the system to work. We have to be able to support transitions in care so that people get the right kind of care that they need in the right way and in the right time. So everything from prevention and early intervention to supportive care, which also really could be, what are the ongoing supports that we're providing people so that they don't end up in more immediate crisis. And really important for us that we recognize, and all of you have shared with us how critical it is just to continue to really think about systemic investments in workforce and really physical infrastructure, both facilities and multiple residential and housing options. This is our newest proposal, and I wasn't planning on walking through it, but I thought that would be just so strange to not walk through it on this this opportunity I have in front of you. So I'm going to go through it pretty quickly, but we have some links I think that you guys can dive into to get some more information. So what are the elements of the proposal that was announced? I think we're just shy on 4 weeks, I believe. We announced the proposal on March 19th in San Diego. So first and foremost, there's a general obligation bond to fund unlocked community behavioral health residential settings. This is really important. This is a general obligation bond. This is not MHSA off the top to fund this work like we did with No Place Like Home. This is something quite different. There are also a number of different proposals to modernize the Mental Health Services Act, and one that's been getting a lot less attention but is really, really important, which is approving accountability and access to behavioral health services, and that is inclusive of work we will be doing with commercial plans. So the general obligation bond, we have not landed on a dollar amount right now. It is going to be somewhere between 3 and 5 billion. It will be on the 2024 ballot. It will build thousands of new unlocked community behavioral health beds and residential settings for Californians with both mental illness and substance use disorders. And there's a set aside within that bond that will be earmarked specifically for housing homeless veterans. So a little bit more about what we mean when we say unlocked behavioral health settings. So the first is really, and again, this is really to support transitions to care. We've got a lot of questions as to why aren't we building more acute inpatient facilities? And what we're saying in response is what we really need, and what we've heard from you and what we've learned from our behavioral health infrastructure program, our BCHIP program, is that we need to decompress acute settings. We need more options to transition people out of higher levels of care so that those beds are available for people who truly are in acute need and need to be stabilized. But once they're stabilized, we need to have options for people to go. And so the first kind of concept is really what we're calling a multi-property setting. These would be residential campus-like settings where multiple individuals can live, attend groups, work on their recovery, and really have pretty intensive stabilization on-site services so that we are really working to build up that person to be prepared to transition out of that setting. The way I like to describe this is you've gotten double knee surgery, or maybe you've just had a major cancer treatment. You don't immediately go home. Right, you go to a rehab facility, you go to a place where you can have more time to recover, especially if you don't have the supports at home or the in-home supports that you need to help you rehabilitate from major surgery or a major medical crisis. The next setting is what we're calling college settings. These are smaller residential settings where there will be more enriched services available on site, but this is really intended for an individual to also really access existing services in the community, to walk down the street and go to the community health clinic, to go out to groups, etc., but also to have the ability to have lower staff ratios, so that there can be enhanced activities within the residential setting. In other words, for those of you, you all know this, you're familiar with these settings. This is like an adult residential facility with enriched services. This would allow you to potentially work with an adult residential facility provider and pay for patches so that you can keep and support somebody who might not be successful in that level of care to get the services that they need, so they will be successful in that level of care. And lastly, and the goal that we want for many of our clients, if not all, is really to support them in their own home environment. And so permanent supportive housing and scattered site housing that really offer, truly integrated long-term housing stability, specifically for our folks who are suffering from more serious and long-term conditions. So modernizing the MHSA, this is also something that will need to go to the ballot. It is a multi-year reform initiative. Some of the reforms we're envisioning starting in 2025, others will take more time. We are going to be updating the categorical funding that you all use with your local assistance dollars and really lifting up housing interventions with the changes. We also will be allowing for the treatment of more debilitating substance use disorders. We know many of you are doing a lot of substance use prevention work as well, and with PEI, but this is, we want to make sure that we also have some additional focus on people who have more severe and significant substance use disorders. And the last piece is really giving us the tools that we need to support accountability. We've actually got a lot of good feedback from counties that some of these suggestions will really be helpful, so that we know the full story of what you guys are doing at the local level, and we can support you accordingly, and we can make state investments accordingly. And also we will be proposing to take the Mental Health Services and Accountability Commission and move it into Health and Human Services so that it's connected to the rest of the entire behavioral health care system and our various different efforts. So what is the focus? The focus is to go back to the core of what the Mental Health Services Act was intended for 20 years ago, and that is to support adults with serious mental illness, and in this case now, substance use disorder, who are at risk of homelessness or who are at risk of being justice involved, and or meet the criteria for our behavioral health linkages under our CalAIM program, and also adults with SMI who are at risk of conservatorship. For children and youth, and we know that there are a lot of children and youth who are served by the Mental Health Services Act and FSP programs. Your data that I've taken a look at suggests that these are really children and youth with serious emotional disturbance or serious substance use disorders who are experiencing homelessness, at risk of that, at risk of being justice involved or involved, and or transitioning out of the child welfare system. So improving statewide accountability and access. So there will be increased county reporting. And this is really because we've been looking at the MHSA in a silo, and I know that's not how you guys look at it. You utilize it as a tool to help you do a lot of different things to leverage other funding sources, but we're not looking at any of that, and it makes it challenging to tell the story, frankly, of the impact of the MHSA, and also for us to understand the stresses that you may be having with other funding sources. So we will be having increased reporting both of realignment and federal block grant spending and all non-federal match. If there is the use of any local county general fund dollars that you're using, what are your reserve balances and what are your true administrative costs? Information on services that are being provided to persons not covered by Medi-Cal, including commercial insurance, Medicare, and the uninsured. We really want to focus on outcomes. If you go and just do a basic Google search, if you were, all of our graduate students here who are interested in this topic, and you can find lots of information about how much money you all are spending on certain things, but it's not so easy to find out what the outcomes are. And that's of no fault other than that we need to change it, because we know that you guys are getting good outcomes, but we simply just have process measures and or fiscal reporting. And so we really want to take a look at, are we reducing the concentration of people with serious mental illness in jails? And are we looking at that on a statewide level? I think something that also is a really significant policy proposal in this large package is to align county behavioral health plans and Medi-Cal managed care plan contract requirements when they are working on the same program areas. And many of you know that we have a new managed care contract plan, and we really want to align those. We also want to report and publish and have you to report and publish annually for your board of supervisors and for the public how you are doing in terms of outcomes and accountability. None of this proposal works if we don't start to really dive in and work with our commercially insured, our commercial insurance partners and make sure that they are also pulling their weight and fulfilling their obligations to provide services for people who are paying premiums to get care that they should be getting. So we will be working to develop a plan between our Department of Managed Healthcare and our Department of Healthcare Services to really truly achieve parity between commercial and Medi-Cal mental health and substance use disorders. We know that this will require phasing in. The commercial system has many of the same challenges, if not more, than you all do in terms of capacity, infrastructure, simply don't even have many of the models of care that you guys are using effectively, like peers. So there's a tremendous amount of work to do, but we are very committed to starting that planning and to do it through a very robust stakeholder process, which will include our health plans and other system partners. We have some new materials that should be posted on our website towards the end of the week, if not early next week, including a pretty significant FAQ. That FAQ was derived from all the different comments that we got in the public webinar that we had about 2 weeks ago. If you haven't watched that webinar, it is recorded and on our website. And I think I might have some links in here somewhere to some of that stuff. If not, I'm sure that the team here can get those to you. So let's dive into the next set of slides. So I don't have to tell you guys because you're scratching your heads, you're running around, you're working yourselves to the bone because we've put out so many resources. And so kind of thinking back about that, that basic graphic that we saw before that really had that simplified representation of the behavioral health care continuum. I think the Children and Youth Initiative really plugs in many of those spaces, but it really is a focus on prevention and early intervention. At this point, we have invested $4.7 billion in reimagining how children and young people and their families access care. I wanted to just really lift up a few things that are on the newer side. I know many of you are probably knee deep in some of the planning initiatives around the Kids Initiative, but one would be, we have a co-designed youth-driven behavioral health literacy and stigma reduction campaign that is launching this year. We dedicated $100 million for it. And, I think back to the days when I used to lead our Each Mind Matter campaign on a statewide basis. And I think we had less than $20 million a year to spend. And you guys have all done amazing grassroots efforts to bring change. But the thing that I'm so excited about this particular campaign is it truly is created and co-designed by young people themselves. The next is really, the next few are really a response from the youth behavioral health crisis that we're experiencing in the last couple of years. And so we have about $140 million that is focused on addressing the complex care needs for foster youth. And also $175 million to focus on the urgent and emerging issues in behavioral health, specifically looking at wellness and resiliency building supports for children and youth on campuses and in school-linked settings, and also a school-based peer mental health demonstration project. And the last bit, the $40 million, is really exciting, our youth suicide prevention and outreach campaign. This is also going to do some testing on reporting suicide as a crisis that allows us to trigger enhanced funding when that happens. And so we're doing some exciting things to try to also tap into additional funding sources outside of behavioral health to really help us address the youth suicide crisis. I think it's also really important to lift up, and this kind of part of what my role is that there are a lot of auxiliary, and you guys experience this every day in your partnerships with social services or local aging partners, that there are all sorts of other systems outside of behavioral health who are incredibly interested in what they can do to support the positive behavioral health of the populations that they serve. So we have an effort underway over $100 million to really focus on older adult recovery and resilience. I'm sure many of you have noticed as much as I have, including with my own family, that our older adults and our aging loved ones have in many cases really suffered from the isolation that the pandemic created, and also frankly the loss of friends, loved ones, spouses, because of COVID. And so there's a significant amount of work that we want to do in this space, including making sure that we fully fund our our older adult friendship line, which is a warm line for older adults. We also have a veterans health initiative, and that health initiative is really also focused on reducing the number of veterans who die by suicide and really trying to improve and enhance the kinds of mental health services that are provided by our veterans partners. So expanding infrastructure, this is one of my favorite areas. It's just such exciting work. I've just had the opportunity to look at the things that you guys are working on at the local level and the proposals that are coming in for our behavioral health continuum infrastructure program. And it's just phenomenal, the creativity, but also frankly, the need. I think honestly, a lot of the inspiration and the advocacy that we did to try to say that we needed this bond came from the fact that you guys are constantly putting in more proposals than we have money for that are excellent for our BCHIP program. So right now that's $2.5 billion. You guys are familiar with that. I'll go quickly. 1.5 billion for behavioral health bridge housing, which is the kind of what we're seeing as the quote unquote bridge to when some of these other investments might materialize in future years. 1.4 billion, much of that is federal reimbursement for our Medi-Cal community-based mobile crisis intervention services. Again, the thought here is like, if we could be out in the field and you're out in the field and you're stabilizing people in crisis or you're preventing crisis, then people do not need to be transported and placed in hospitals, et cetera. And then we do have an augmentation here for our 988 centers, as well as our California Peer Run Warm Line that is operated through CalHope. I actually came to this position after being at the California Department of Corrections and Rehabilitation for 5 years. And my job there was really to not only just prevent people from getting there who have serious behavioral health conditions, but making sure that they get the care and support and the integration that they deserve when they return home. And it was so amazing to see so many of the accomplishments that that we have had in this space and this dedication in this space. And so first and foremost, I want to say for the first time in a very long time, several years, we actually have a significant reduction in our IST waitlist. So just thank you to all of you out there who are working very diligently to serve this population in a variety of different ways. Very grateful. This is a population for me personally that I feel often doesn't get the treatment and the services that they deserve. And I'm so appreciative for the hard work that you guys are doing in this space. We also are really wanting people to be ready to come home and keep working on their rehabilitation. So continuing to really expand our ability to provide integrated substance use treatment while people are incarcerated, so that when they come home, they're ready to continue that journey of recovery. We have also dedicated state general fund to continue the California Reducing Disparities Project, so that we can better understand from a community-based organization perspective how to create and design community community-defined practices that work for cultural communities. And also behavioral health is a very central component to our equity and practice transformation provider payments. I can't go anywhere and not talk about workforce. And so I, don't have to go into a lot of detail here, between the workforce investments that were attached to the Children and Youth Behavioral Health Initiative and the ones that we were able to secure last year through the budget process. We have over 1.4 billion secured to invest in hiring, training, and advancing a diverse behavioral health workforce. For those of you out there like me who are still paying off their student loans when I got my MSW, make sure that your staff, as well as you, are out there actively applying for all of our available and open loan assumption programs. And then there's a bunch of other things there, but I think one of the things we're really excited about is really thinking more creatively about what our workforce looks like, making sure that we're investing in things like behavioral health coaches, peers, community health workers to really not only develop a workforce that is committed to serving their communities, but also is from their own communities and wants to serve their communities. So I put this in here kind of at the last minute because I realized I put this whole presentation together and forgot to talk about 988. It's a really big, important thing, but real quickly, we are getting ready to publish a crisis care continuum plan, which is basically like a statewide strategic plan for the crisis care continuum, of which 988 is a part of and central after the passage of AB 988 last year. The plan itself has really three pillars of kind of strategic priorities. One is to create consistent access statewide. And that's really just acknowledging that regardless of your payer, and regardless of where you live, regardless of the language or the native tongue that you speak, there are some core crisis services that everybody should have access to. And also really wanted to focus on, in order to achieve this, there is significant amount of outside and across system coordination that has to take place. And then lastly, what are those crisis services and are they truly equitable? Because we all know that people experience crisis in different ways, and unfortunately, really negatively for many of our BIPOC and LGBTQ communities. So the plan itself is a strategic plan. It really talks about near-term, medium-term, and long-term milestones. We also have some suggested metrics that could be used to kind of monitor if we're making any progress in this space. And so the next steps on all of this work is that the plan itself, it is literally at the graphic design stage. So it's approved. We just need to get it out the door. We will be completely refreshing our website. Right now, Health and Human Services is really kind of the hub and leading efforts around planning for AB 988's vision that it has identified. So we have the responsibility in that legislation to develop a 5-year implementation plan to achieve that vision. We plan on launching that process in July. We are going through the budget process. We have a very similar process like you guys locally. We currently don't have any budget authority to start doing this work, but are very excited to hit the ground running in July. And we have already been very active with planning with Cal OES, and they've been really diligent, already have a lot of activities up. So if you're interested in more information, I've got some hyperlinks embedded in this slide. I know you're also getting a presentation later on AB 988, so we'll just keep going. I'm really excited about our community-based continuum demonstration. This is part of our overall CalAIM commitment. This is, we committed, honestly, I think we might have committed before the pandemic, I can't remember, to pursuing this particular waiver. Guidance came out in late 2018. And, I think, the idea is to kind of really explore being able to get reimbursements for those things we call IMDs, those residential treatment programs with more than 16 beds. And I think what we believe is that if there's more options, kind of like what I was talking about the bond earlier, there are more options to transition people to the right level of care. We can move people through things much quicker. But right now, all of you know that the length of stay in an IMD in many cases is a very long time. And that's because there's no other options for people. So we really excited to work on that and really bring the treatment of people with severe behavioral health challenges into the 21st century and have people treated at parity as they would with other major physical illnesses. So there's a concept paper. I'm sure you guys are kind of in the thick of taking a look at this. Some of the other things to really lift up is very consistent with other themes of this administration's priorities. Really want to target reducing either the experience of homelessness or the risk of homelessness or housing insecurity amongst our SMI and SUD populations, really want to focus on children and youth, and really want to focus on justice impacted folks. So some of the goals that we really want to amplify in this approach is that it really is about this overarching, and it's why I started with that continuum of care graphic. This is another effort for us to try to inject strength across that entire continuum. and really make sure that we're using like evidence-based practices through Medi-Cal. Like we are really stretching our Medi-Cal muscle, and really to clarify coverage requirements for evidence-based practices for kids. We also want to support practice transformation. And so there's a way in which we can provide more training. It was really exciting to hear about this project, actually. I was so pleased to hear about that. And how can we improve the quality of care that's really delivered in these residential and inpatient settings, again, with the goal to be able to stabilize people quickly and support their recovery, but transition them to the least restrictive environment possible and to community settings. We want to improve accountability, but we want to do that by providing robust technical assistance. And again, part of the gem in this is really allowing you all to receive FFP for services that are provided during short-term stays in an IMD. I think, these are just some of our major goals summarized. Again, strengthen the continuum with some really kind of, I think, innovative strategies like activity stipends and cross-sector incentive pools. We want to support transformations in connecting people to appropriate care, statewide accountability of Medi-Cal services. These are just performance measures and streamlining performance reviews. I know you guys are sometimes drowning in paperwork. The work is really intended to make less paperwork and more time with clients. So we are working on reviewing boatloads of comments. I'm not DHCS, so I have not gone into an in-depth presentation on this, but I do know that there's just thousands and thousands of comments that we're working on incorporating and working on a submission to CMS. So I think I'm wrapping up with a few slides on the CARE Act. And the CARE Act was SB 1338. It was signed by the governor last fall. The eligible population are people with untreated schizophrenia spectrum or other psychotic disorders. We estimate that number is somewhere between 7,000 and 12,000 Californians. So really a very small group of people, much smaller than who's eligible for assisted outpatient treatment. CARE is a new process that is intended to be served, that people are intended to be served with existing programs other than the behavioral health bridge housing. I mean, you all know this, I don't have to tell you that obviously if they have untreated schizophrenia and psychotic disorders and they're potentially living unhoused, these are just really excellent candidates for full service partnerships. Again, the primary driver of this particular program is upstream diversion from more restrictive conservatorships, or unfortunately worse is incarceration. We spend so much time creating our IST felony diversion program. People also know that on the books, there also is just basic mental health felony diversion. You don't have to be deemed an IST. We're sitting here going, why should we wait to do this why should we wait until somebody has been charged with a felony crime to do this work? We really need to try to figure out how to do it earlier. So next slide. So the CARE process involves a petitioner. It involves all of you, County Behavioral Health. It involves the civil court, not the criminal court, legal aid or a public defender, a voluntary supporter if that's what's desired by the person who is participating in care proceedings, and a comprehensive care plan. And we're going to talk a little bit more detail, and then I see the time and I'm going to go through this pretty quickly. A few things that we like to point out, different than Laura's Law, or our assisted outpatient treatment or LPS conservatorship. So CARE is not intended to put people in custodial settings. It doesn't have the authority to provide long-term involuntary medication. Those are all that has to be done in an additional process, if that's appropriate for someone, right? And it's significantly different by who submits the petition. It could be a family member, it could be a clinician, a physician, it could be a first responder. It cannot be law enforcement unless they're part of a mobile crisis team. But and so I think that's also a misnomer that's still kind of out there. You do not have to have multiple incarcerations or hospitalizations to be eligible. You don't have to basically fail multiple times to meet eligibility. And then this new concept that we're really trying to refine, and I'm really doing it with a lot of our cohort 1 counties, is what is the supporter's role? We know that they are there to provide supportive decision making, which is a best practice that we're really trying to apply to our system that has been in the IDD community for quite some time. And also potentially the supporter would be assisting with developing a psychiatric advance directive. I know many of you guys have been working on this as well, if that's something that the client was interested in having. And also significantly, for all this audience, we're well aware of this piece, and we'll get to in a second, which is that the civil court, the judge in the civil court, has the authority to sanction counties if it is found that there is a non-compliance with court orders. Next slide. So a lot of people ask, like, why did you even involve the courts? If this person has not committed a crime and they're not yet conserved, what is the purpose of the courts? And I think for one, what we especially heard from our court partners is that these are all people who are already in courts. And I don't know how many people on this particular call are doing work in your diversion courts, your drug courts, your mental health courts, but those are all criminal courts. And so this is intended to really make sure that we go upstream with a civil court process before a criminal court process or a conservatorship is needed. And like collaborative courts, the spirit is collaboration and coordination. It's not about compliance or coercion. Really thinking through some exciting and innovative ways to make sure that that becomes a reality in some of the conversations we're having with our cohort 1 counties. And really the intent is for the court to have a light touch. The court can deepen its engagement and oversight if needed. And also, as you guys have probably come to know in diving into the details around care, the client themselves can refuse to participate and there are no particular consequences. Next slide. So who is eligible? This is really important. I also think we've certainly identified with our cohort 1 counties that that getting the word out about this is really important. And so we are working through some strategies on how we can do that effectively. It's not as simple as probably just publishing a piece of paper. It needs to be a real concerted effort, but it is a very small group of people who will make the eligibility criteria. So we really need to manage expectations and be clear now that we're past the development phase and we are in the implementation phase about who is eligible. So you guys can read that slide for yourself. I don't need to go through it in detail. We can go to the next one. Here's just a list of people who can file a petition in more detail: a hospital director or their designee, a public guardian, some of the things, adult protective services. And this is important because all these people need to be trained to make sure that they are clear, that it's clear, so they're not, wasting everybody's time with putting together petitions that, people are just not going to meet criteria. The petitions must also include an affidavit from a licensed behavioral health professional that, says that this individual is and has a diagnosis that meets the criteria. And that evidence that respondent was detained at least 2 times with the 5250, and the most recent one has to be within 60 days. I hope that I'm underscoring that there was a lot of thought that went into focusing not just on, it wasn't just about wanting to keep the population small. That's not the point. The point was These are individuals who have significant needs, and the intervention that's matched with it is something that's going to work well for them. It's a good fit. Let's go to the next slide. These are super helpful flowcharts, but we don't really have time to go through them in detail. You guys can take a look at them on your own. I hope they're helpful to you. We've really simplified some of this, and we've got the petition to the initial court hearing, and the next slide is really future court hearings for someone who does end up having a care ordered plan. I almost took them out, but I thought you guys would like to have them. It takes me a while to go through them in detail, but this is really important for all of you in county behavioral health land. Is right. The care plan is really what you do already. You're sitting down, you're developing an individualized plan, and the supporter, if someone in care wants to have one, can be present in this process. Housing is a critical component of that plan. Similar to many of the things I've talked about today, for this particular population, those enhanced interim bridge housing settings could work. An adult residential or senior care setting with enriched services might be an appropriate setting. Supportive housing, certainly during the course of the 12 months that someone's in care, it might be appropriate off the bat, but more likely to be something that they would transition into. And the court may issue any orders necessary to support the respondent accessing the services and supports that are identified in the care plan. And that includes prioritization and creating an order of prioritization. The plan is up to 1 year. There's some status reviews that are set by the court. Next slide. We get a lot of questions about, won't someone be in there for another year? You have to, at that year point, what we're describing here in this 11th month, when there's a hearing, you'd have to completely meet the criteria for care again, and then the client would want to have to, be in care. So again, really, really high bar. I think that we see that this 12-month period as an intensive period, and also a real good time to plan about what happens the day after the 12th month. And that's why there is this kind of voluntary graduation plan. Counties are not held accountable by the court to what happens after that 12 month and what's in that graduation plan, but it's what you would do anyways as a transition plan of care for ongoing treatment for an individual who has this serious of a behavioral health condition. I think we've already talked about this. Even though there are sanctions, they basically go back to you, and you are directed to invest those sanctions dollars into improving resources for this population. I think that's also something that doesn't get talked about very much, so I hope that you know that. I know that many of you are probably not in Cohort 1 counties, and we really are thinking through how to bring training and technical assistance online very soon, but super grateful for our Cohort 1 counties. Many of them really do see themselves as doing this and wanting to share with all of you and all of the Cohort 2 counties everything that they've learned. We really have created a learning environment, and I look forward to more opportunities to do that. This goes a little bit about the funding. Just wanted to acknowledge that while there is some funding out there, obviously you all are in the middle of pulling together your applications for your bridge housing funds right now. We are in constant negotiations ongoingly about the ongoing admin funds. That includes behavioral health county admin, as well as admin for public defenders, and as you all have brought to our attention, county council. Right now, we earmarked in this budget $108 million for county behavioral health admin cost, but we continue to have ongoing discussions about that particular number. Just wanted to outline who your primary technical assistance providers are. DHCS, of course, will be the lead for county behavioral health agencies, but also for council and supporters, while judicial council will be doing judges. We meet monthly. We meet multiple times per week, actually, already on coordination in this space between the judicial council and DHCS. So there is an annual report. We also have some health equity assessment measures, and the next slide talks about the independent evaluation, I believe. Yes, and we will have an element of that. Certainly, people are very concerned about this just perpetuating existing realities, which is we have an overrepresentation of Black males in particular who are homeless in the state, as well as who are inappropriately diagnosed with schizophrenia. So we're going to do some research in this space to try to understand that issue, as we certainly don't want to perpetuate it, but we don't want to ignore it. It is reality, and we have to do something about it. That's kind of what I shared in the last one around doing our implicit bias training and doing some research so that we can try to get at the core of what are some of these challenges and drivers that are creating this bias. That's a nice summary of each of the three of us and our major responsibilities in care. You guys can dive into some more details later and look at all of those details. This isn't that exciting, but I'm very appreciative of the counties of, I think, Fresno, Tuolumne, Orange. If I'm forgetting a county, I'm sorry. In terms of actual county staff, actually Sacramento has their social services director who participates on our CARE Act working group. And this is really us wanting to have a very public forum and ongoing stakeholder engagement to make sure that we implement care in a way that's going to work for people, that is right and just and is appropriate. And so, yes, we got a lot of flack for this, but we invited people and feel very strongly about inviting organizations who are not supportive of care to be at the table with us to figure out how to implement it in a way that is socially just, that is, and frankly gets us the outcomes that we want. Okay, lots of information that you can find on the CARE Act and implementation status on the last page.